Okay, everyone, welcome to the Compass Connections webinar on ADHD. This is number 3 of our series on ADHD today. For anyone that doesn't know about Compass, we're coming to you from Vancouver, BC. My name is Helen Kennett-Bacon. I'm a nurse clinician in Compass and also the intake coordinator for outpatient psychiatry at BC Children's Hospital. We'll start with a land acknowledgement. We acknowledge that we work on the traditional, ancestral, and unceded territory of the Squamish, Musqueam, and Tsleil-Waututh nations. So anyone who doesn't know about Compass, we are a telephone consultation line for healthcare providers. Our goal is to build capacity for healthcare providers in the community to treat mental health and substance use, to provide assistance with complex cases, and to help navigate the mental health system. And we also provide support to healthcare providers who are treating young people up to the age of 25. So today's webinar is session 3, Rolling with ADHD, a clinician's guide to supporting families and children with ADHD. And our speakers today are Dr. Randall Gillis and Dr. Janet Ma, psychologists in the outpatient psychiatry department. So just a little bit of housekeeping information. So we will automatically mute your speakers and turn your cameras off. We're asking you to submit questions for the talk today through slido.com. The code for that to access it is 534699. And at the end, we did adjust our talk today. We will actually be doing the talk until 1 p.m. and then there'll be time for questions between 1 and 1:15. For anyone that's not able to stay with us that entire time, we are recording this and it will be on the Compass website probably by the beginning of July. If you have any technical questions, please put them in the chat function and the Compass project managers and support staff will be there to help you. At the end of the talk today, we will be sending out an evaluation survey that's for the whole of the webinar series. For anybody who's a physician, this talk is accredited and the information you'll see is on the slide. We will be putting the talk and the slides on the Compass website afterwards. So just in terms of disclosures, I have none. We hope that today the goals of the webinar series have been, the learning objectives have been to be able to identify ADHD in children and youth, including comorbidities that increase its complexity, to be able to describe evidence-based guidelines for assessment and intervention for ADHD, and to recommend and/or deliver appropriate pharmacological and, today, non-pharmacological interventions to manage ADHD or ADHD symptoms with children who do not have a diagnosis. So I'm going to pass you on to our speakers today. We have Dr. Randall Gillis and Dr. Janet Ma, who are both clinical child psychologists in the ADHD and infant psychiatry clinics of the outpatient psychiatry department here at BC Children's Hospital. They have expertise in evidence-based cognitive and behavioral interventions for children and youth with mental health difficulties, and they're engaged in clinical service and research of parenting supports for ADHD. And they're also clinical faculty at the Department of Psychiatry at the University of British Columbia. So with that, I'm going to pass you on to Dr. Randall Gillis.
There we go. All right. So welcome, everybody. Thank you for joining us today. Before starting, our own disclosures are that we're both employees of BC Children's Hospital, and Dr. Ma has research grants funded by BC Children's Hospital Foundation and Research Institute. So our goals for today are to discuss the rationale for behavior parent training as an intervention for ADHD and to introduce you to the Rolling with ADHD course so that you're able to use this as a resource with clients. So you will know from the previous talks in this series that ADHD is a brain-based disorder and that there are a number of evidence-based pharmacological interventions. And if you want to know more about these, the recordings of these previous talks will be available on the Compass website. So today we're going to be addressing the evidence-based non-pharmacological interventions. So to do this, we can consider the biopsychosocial model, which says that child behavior is a product of biological factors, the child's own psychological experiences with the world around them, and the social context, which can include peer influences, teachers, and parents. We will be focusing on evidence-based behavior parenting strategies. So it's important to note that these strategies do not necessarily change the core symptoms of ADHD, but they can improve child confidence, parent-child relationships, and help to ensure that the symptoms of ADHD are not as impairing. So for example, parents aren't necessarily going to be able to expand the child's attention span per se, but they can learn how to communicate in a way that makes it more likely for the child to succeed at completing a task that they are requested to do.
So treating ADHD is not just about the meds. The best practice is a combination of stimulant medication and behavioral parent training. In fact, there's a neat study that found that if families receive parent training first, followed by meds, then there are significant impacts on better child behavior in the classroom and less oppositional child behavior at home and at school. So today we hope to equip you with the foundations of the behavioral parent training strategies so you can support families of kids with ADHD. But first I want to address some common challenges that are often raised with regards to behavioral parent training. So there's common misconceptions that behavioral approaches undermine attachment security, just as there's a misconception that attachment approaches lead to permissive parenting. But we view these approaches as complementary because both of them really emphasize positive parenting. So the concepts of being with a child aligns well with the strategies of positive attention. Similarly, the concept of taking charge, it corresponds really well to the strategies of setting limits and teaching regulation skills. Now, most parents recognize the strategies that are often suggested in parent training, and they may even say that they've already done them or that they're just common sense. But in behavioral parent training, each strategy is akin to like a tool in the parenting toolbox. And we seek to equip parents not only with the tools to use, but to enhance their knowledge and understanding of the underlying principles so they know what each tool is used for, when and how to use them well. Just as you can't use a hammer to solve every problem, it doesn't mean that a tool is ineffective, but it has to be used in the right way. So for example, people say that, oh, sticker charts work only for a week or two. Well, that's because it's due to, diminishing interest or motivation that naturally occurs over time. So fine-tuning and updating the system is needed to sharpen the tool when it becomes dull, rather than throwing out the tool completely. Now, these strategies are helpful for all kids, regardless of diagnosis or condition, but with ADHD, there's more complexity and intensity of behaviors. So implementing the strategies need a level up with more precision and consistency. So we hope that as clinicians, you can help support parents in doing this well. So consistency is important because behaviors don't change overnight. So because ADHD runs in families, then a lot of parents themselves will struggle with their own attention and executive functioning deficits. So parents may need some help in acknowledging that they need their own self-care and to meet their own mental health needs in order to become effective. And that really speaks to your role as a clinician to help coach and model the strategies for these families. Also, consistency between caregivers is important, as often there's people that might have different caregiving styles or beliefs and attitudes and expectations about their child's behaviors. So there's your role as a clinician to help guide and integrate the differences between caregivers towards best practices. Another common challenge in working with parent training is that there's barriers to following through with implementing the strategies. Barriers such as parents' own readiness for change, as well as difficulties in just meeting the competing demands of a busy life, as well as times of high stress or moments of crisis. So how you can help accommodate for these barriers is through flexible timing. So maybe exploring motivational interviewing through some prep sessions before starting to teach about the behavioral parent strategies. Or taking more time, so more than a week, to review and implement and follow up and fine-tune each strategy. It's also important for you as the clinician to help address the feasible targets. So we don't want to address all behaviors all at the same time. So just focus on making one small change at a time, because then that's more likely to have efficacy and more likely to build the parent's confidence, and then you can slowly externalize and extrapolate to other scenarios. Also, it's important to help accommodate for ease of access to these strategies and approaches. So perhaps encouraging more in-session work. You can adapt it to either train parents and as a parent coaching only, or you can bring the parent and the child in and do some coaching directly in the moment with them. The use of handouts can be helpful to provide for families as well, and maybe possibly explore options for midweek reminders.
So the good news is that we already have a great free online resource called Rolling with ADHD, which clinicians can access and provide to their clients. Clients can work their way through these modules, but as with most self-directed interventions, this is often best completed with some support. So our goal today is to orient you towards the Rolling with ADHD program and to go through some of the common challenges that arise in each module so that you can more confidently support clients in completing it. The Rolling with ADHD is a free 8-module course designed to be completed over 8 weeks. Each week has a 15 to 20-minute video to watch. It is designed for parents of children ages 6 to 12 and was created by the BC Children's Provincial ADHD Program. This is the website that is used to access Rolling with ADHD. Parents can enroll themselves by going to this website and signing themselves up, and clinicians can also access the course in the same way. We recommend that clinicians work through the modules to familiarize themselves with the content before offering it as a resource to their clients. You can see that each module comes with a video, an area to make notes, questions to answer, an infographic that summarizes the content, weekly homework assignment called the Fridge Drawer Challenge, and some additional materials. If parents are motivated and able to watch the videos on their own time, you could utilize your time with them to debrief and offer suggestions and help them to implement the homework strategy. However, it may also be necessary to watch the videos together. They are short enough that this would be possible to watch one full module within a session together. And here's an example of the praise module infographic. All of the infographics, as well as the notes that are made, are available to download and print. So the infographics can be used as handouts in your office as a way to introduce families to the content. So let's look more closely at the content and common challenges that arise in each module. As Dr. Ma discussed earlier, the foundation of behavioral parenting programs is positive parenting strategies that help to increase the attachment between parents and children. For this reason, Rolling with ADHD starts out with praise as the first module. Praise is helpful because children are motivated to increase positive behavior when it is noticed. Parents are taught how to praise effectively in the module by being specific. So for example, saying you did a great job sharing your stuffy with your sister as opposed to you're being a good girl. Also making sure that their praise is brief so that children understand what is being said, that it's immediate so children tie the positive behavior to the praise, and that the praise happens often so that the message is sent to the child frequently. Praise can be done both verbally and non-verbally with things like hugs, smiles, and high fives. So what are some of the common challenges to implementing praise? First, parents often don't realize that they aren't praising enough. We know that children with ADHD get much more negative feedback than their typically developing peers. So parents need to work hard to praise even more than they think they should to get closer to the recommended 5 positives to 1 negative ratio. A really helpful strategy, albeit a difficult one to complete, is to get parents to record themselves and then listen back. So for example, they can do this during the morning routine so that they can actually hear how often they are praising. An alternative to this is to ask parents to keep track and record of how many times they're praising in a certain period of time. Another way to help balance out this ratio is for parents to start to be more mindful of what directions and corrections they give. If it's not something that's necessary, so for example, sitting while eating dinner, we encourage parents to try to not give the direction. So for example, they might not need to tell the child to sit because it just might be fine for the child to stand and munch away at their food. Sometimes parents get overly invested in the outcome of a behavior and forget to praise even though their child is trying hard. So parents should be encouraged to be descriptive and say something like, I'm impressed at how hard you worked at drawing that cap. Parents often forget to prioritize praising, especially when they are busy and trying to do something like get out the door in the morning. It helps for parents to focus on praising only 1 or 2 specific behaviors at a time, so they're more likely to remember to praise. This also helps to increase the likelihood of behavioral change occurring for those target behaviors because the child gets frequent reminders that their parents appreciate what they're doing for that specific behavior. Sometimes parents will say that they can't find anything to praise. In this case, it is helpful to ask them to think about what the opposite of the negative behavior is and to try to praise any approximation of this. For example, if they're working on decreasing how much the child yells, they could praise talking in a quiet voice. It is also helpful to praise the absence of behavior. For example, saying, wow, you are sitting so quietly. Lastly, parents sometimes are concerned that they're going to spoil their children with praise. As long as praise is being done appropriately, it's not possible to overpraise. So continuing with building that positive foundation and focusing on the parent-child relationship, the second module addresses play. Play helps to create a positive parent-child relationship. It builds self-esteem for the child, and it provides an opportunity for parents to reinforce positive behavior. It is important to note that the play that is incorporated into behavior parent training programs is a special kind of play called child-directed play. This means that during this time, the child is the leader, and the parent's job is simply to follow. This is distinct from most of the other times when the parents are in charge. To do this, parents must act more like a sports commentator who does not try to teach or ask questions. Instead, parents need to make descriptive observations and comments and praise behavior. The first challenge here is that parents often think they are already playing with their children in this way. But this is actually really hard to do. Parents usually have a really hard time stopping themselves from asking questions and trying to direct or teach. If they aren't finding this hard when they first try it, they probably aren't doing it correctly. It can be helpful to role play with the parent to see if they are able to do this with the clinician pretending to be the child. The clinician can then offer observations and suggestions. Parents can also be asked to track their behavior during play, for example, to notice how many questions they ask. Sometimes just bringing this awareness can help them to stop themselves from asking questions. Sometimes parents think they play with their children more than they do. However, when they rely on play happening spontaneously, sometimes it does not end up happening enough. We strongly encourage parents to schedule this child-directed playtime. Scheduling also helps when there is more than one child in the household. By scheduling, parents can help to make sure that each child gets some one-on-one time with each parent. If it's a single parent household, this can be really difficult, but if possible, organizing some childcare or planning playtime while the other child is busy with something else can help. Finally, parents, especially those with ADHD themselves, can be easily distracted, and therefore it's important to set up the playtime in advance so that there are minimal distractions. For example, having parents put their phones away.
Module 3 covers how to give effective directions so that it increases the chances that the child with ADHD will follow through with what is asked. So a focus on this module and the strategy is to watch what parents say and how they say it, with the keys of reducing the amount of talk and commands, as well as breaking tasks down into one single step at a time and pairing it with visuals as opposed to only relying on verbal instruction. So to further help families with this strategy, encourage them to set up the physical environment to reduce distractions or triggers by putting them out of sight. Also, kids with ADHD will habituate to things much faster, so keep visuals updated in creative ways every few weeks. Or else, if you're using the same visual over time, then it loses its impact. Some examples of these types of visuals would be like having a wait card that kids physically have to hold on to while waiting for their turn. Or instead of a checklist of items to do, then putting tasks on one end of a popsicle stick, and then when each task is finished, flipping it over and it says done. Visual timers that provide countdowns for transitions are also helpful and come in many different forms. There's the visual timer where the red zone gets smaller and smaller as time runs out. And there's lots of phone apps that do a similar thing, or use of an hourglass timer or kitchen timers. Transition warnings are important, as well as offering controlled choices, particularly in having kids do things that they don't want to do. So it's not giving them a choice of whether they want to do it or not, but maybe a choice of how to do it or where to do it. Giving choices is particularly important because it decreases the power struggle that often happens, and you're giving some element of control back to the child, which increases the chance that they're more willing to comply. This is not part of the Rolling with ADHD program, but this website has excellent resources like these infographics on a variety of different behavior management strategies. So you can refer to some of these to further support your families. They can print it out as refrigerator, like reminders throughout the week. Module 4 covers the strategy of ignoring, or also known as differential attention, because it's not ignoring the child, but you're strategically paying attention to positive behaviors and withdrawing attention from two very specific types of behaviors only. So one of those behaviors are those uncontrollable ADHD behaviors like fidgety and making verbal noises with their mouths while they're working on tasks. Yes, those behaviors can be annoying, but they're not impacting functioning. They're still working while they're, fidgety and making noise. So it's better to ignore those minor behaviors and instead praise the more important and functional behavior of completing tasks. Another instance where you might use this strategy would be for behavior that's fueled by getting a reaction from others. Things like whining, interrupting, swearing, negotiating, arguing. So those types of behaviors, the more you comment on it, the more it's fueled and the more the behavior continues. So it's really important to check the function of the behavior, or what's the driving force behind the behavior. So for example, a child is playing with his food. Well, if the function of it is for the purpose of escape or avoidance of eating a food that he doesn't like, then ignoring it is not going to be effective. However, the same behavior, playing with the food, could have a different function in that it's getting a reaction from other people. Maybe a sibling is laughing, or a parent is commenting on that behavior, in which case then that behavior of playing with the food is fueled by attention, and so then this strategy would be appropriate. Also, we suggest for parents to front load the child by giving him a warning that from now on, I'm going to not pay attention when you keep interrupting me or keep asking me the same question over and over and over. I've already given you an answer. Also, super key is to warn parents that it's almost 100% guaranteed that things will get worse before they get better. So with this strategy, it's kind of like a vending machine analogy. Kids know which buttons to push in order to get a response. But if you're changing tactics and using this strategy, then when they push the same buttons, they're not getting a response anymore. And we know that it's very unlikely that they're just going to calmly accept that. They're going to escalate. They're going to push the two buttons more. They're going to maybe intensify their behaviors by pounding or shouting or screaming. So prepare the parents for that, that reaction. And eventually, if the parents are consistent, then the child will learn over time. But it's worse if the parent cannot take it and the child's escalating the behavior and then giving him attention back at that escalated time. It's actually worse because we've just inadvertently reinforced the escalated behavior. And that's what we see often when kids kind of go seemingly from 0 to 100, is because they learn, I don't need to kind of do all these steps in between. I'm going to get the reaction that I want when I move to 100. Also, when one parent tries the strategy, it's important to have consistency among the family members present. For instance, if one family member is ignoring the playing with the food, but then the sibling is giving that attention, then it's going to be not effective. Also, the important thing is that you're ignoring that specific behavior for that specific purpose, but you're staying close and remaining neutral. And this is way harder than it actually sounds. So we want to support parents in, their own self-regulation and mindfulness. But the important thing is that they're present so that they can provide immediate positive attention and praise when the child does something good, or even when the child stops that annoying attention-fueled misbehavior. Module 5 covers incentives. So this is to acknowledge that some tasks are difficult for kids with ADHD. So in order to motivate them to put in all that effort to climb over the mountain, it's really nice for them to know they can earn a reward afterwards. But it's really important not to reward all behaviors all at the same time. You want to be strategic in using this approach to only 1 or 2 targets maximum. And you're making the targets feasible, just kind of beyond what they're currently able to do, so that it's achievable with a bit of effort and support. Also, it's important to offer a wide menu and variety of rewards for kids to choose from. And these rewards should not be things that they can obtain through other means, or else then they don't have the motivation to put in the effort. Make sure that the rewards are being given about once every few days, or else you're going to lose interest if the goal is too long-term. A very common question we always get from families is that, oh, isn't this bribing my child, and isn't that bad? Well, we want to distinguish that bribery is different from incentives. Bribes can be given before they actually do something good. So here, you get something, but now you owe me later, and we know that doesn't work. Another differential is that bribery is often given in reaction to a child's escalated behavior. So, you're asking the child to do something they don't want to do. The child fusses, makes a big tantrum, kicks and screams, and then you offer, okay, fine, you can have this candy if you just quiet down. Well, that is bribery, because then you're actually reinforcing the immediate behavior before that, which is the tantrum. So we don't want to offer rewards for basically raising a stink, right? So you're using incentives proactively and strategically ahead of time. Also, this idea of incentives is actually adaptive across the lifespan. So adults actually get incentives almost every day. Your adults get paid for doing their work, and that is a natural incentive that will follow kids as they get older. Now, many parents have said that they've tried these kind of reward systems or sticker charts, and they've only worked, 1 or 2 weeks, but then everybody kind of loses interest. Well, the important thing is that you need to refresh how it's presented in order to keep that interesting. So the tool itself is not ineffective, but again, you need to sharpen it to keep it from being dull. So if you're kind of starting off with stickers, then maybe changing it over to marbles in a jar instead, or earning, different puzzle pieces that you can kind of put together, and once the whole puzzle is done, then the big reward comes in. Also, as good habits start being formed, where the kids are successfully completing the target behavior consistently over time, then you can start gradually fading the frequency of rewards so that they have to do more before they get a reward, which goes the same where eventually you can kind of advance or level up the target behavior to a different level of difficulty before they get the reward. Module 6 teaches problem-solving skills in a collaborative and proactive way between the child and the parent. So the key to this is to help plan appropriate times for these types of problem-solving discussions when everybody is calm, not in the midst of a high escalated kind of situation, not right in the moment, and also not right after a big blow-up has happened because everybody is drained. Help parents to set expectations about how much their child can contribute and lead these types of discussions. The younger the kid, then the less significant independent contributions they're going to make on their own, but the parent is laying down those foundations of the problem-solving skills through guidance and collaboration. Very important to get the child's perspective about a specific difficulty. So it might even take a bit of time to have the child kind of be feeling safe to express what they're thinking and feeling without the anticipation of being punished or reprimanded about. Also, it's better to kind of get the child's perspective before the parent kind of comes down with their own ideas. Also, try to make the problem-solving times short and sweet and make it fun and engaging, especially for kids with ADHD who have poor attention and focus. So this fun time can also be applied during that brainstorming of solution time, where you're accepting and maybe even offering lots of silly answers, silly solutions that may not actually work in reality. But the important thing is that research shows it's the quantity of solutions provided that's more important for future success than getting the one perfect, reasonable solution. And that's because the more diverse solutions you can come up with, it leads to more flexible thinking, which is a better indicator of future success. Now, even with a well-discussed, agreed-upon plan between parent and child, you need to make sure that parents know they are still responsible to actively prompt the child and guide them through the actual implementation, as well as working collaboratively in evaluating and adjusting the plan over time. Now, this collaborative problem-solving approach is primarily from Ross Green's work, and he has some really nice resources online that can be used to support this module. Now, we do note that unlike Ross Green's perspective, we really believe that this strategy is one tool out of the whole diverse set of parenting toolboxes, and it complements the other tools very well.
Okay, so Module 7 addresses self-regulation. It's normal for children to be upset at times, but parents can help to reduce their distress. It's helpful for parents to identify common triggers for their children and themselves. This can help them then to plan either to avoid the triggers, if that's appropriate, or to help themselves or their child to get through the triggering activity as smoothly as possible. It's really important for parents to learn about their own self-regulation skills first and foremost. If they aren't regulated, it's going to be hard to help their children to regulate. One of the most common challenges when it comes to self-regulation strategies is that parents only prompt these when the child is upset. Skills like deep breathing are like any other skills that need and take time to learn. It's best to teach these types of skills like deep breathing when the child is in their best learning mind, that is, when they are calm. If not, the child ends up getting prompted to do something like deep breathing when they don't know how to do it properly. Then the deep breathing is ineffective and they start to associate deep breathing with being upset. These experiences often lead children then to start to refuse to try these calm down strategies. So instead, parents should start teaching these skills when children are calm, for example, at bedtime. After the child is able to deep breathe properly like this, they can then be prompted to practice deep breathing in situations that gradually get closer and closer to the child being upset. It is also helpful for parents to be proactive by brainstorming activities and items that help them and their child to calm down so that they can have the necessary tools available when needed. Sometimes it can be helpful, for example, to create a calm down box. Sometimes parents make the mistake of trying to reason with their child in the moment when they are upset. These types of serious conversations should only occur when the parent and child have had a chance to calm down. Finally, instead of trying to problem solve, especially in the moment when the child is upset, it can be helpful to instead validate the child's emotions by saying something like, I understand you're sad that you can't see your friend today. I feel upset when I can't see my friends too. In this way, parents are acknowledging the emotions, and it's important to note that we can never tell someone else how they should be feeling. Children's emotions are always valid. The final module is consequences. This is the last strategy to use after all the positive strategies have already been implemented. The premise behind this is that behavior followed by a negative consequence is less likely to be repeated. Similar to the other modules we've talked about, it's important to be clear and to follow through when giving consequences. In this module, parents are introduced to 3 different types of consequences and how to use these. The first challenge is when parents overuse consequences. These should be used sparingly. If consequences get overused, they will not be effective. It is also important to note that if the positive foundation and relationship has not already been built between the parent and the child, consequences also will not be effective. Another challenge is with parents being able to tolerate natural consequences for their children. It can be hard to see their child go through a tough experience, and often parents want to jump in and rescue. However, natural consequences, things like if you don't wear a coat, you'll be cold, or if you don't study, you will fail, can be really helpful for children to learn from. Parents should try to ask themselves, what's the worst that will happen? And challenge themselves to allow their child to go through some small discomfort in order to learn. We know that this is important as well as children get older because they're not always going to have parents around to rescue them. So for example, a parent might say to themselves, well, if he doesn't wear his coat, he'll be cold for a few minutes on the way to school, but there's no real significant danger to them. So maybe I can let them have this experience. Sometimes parents mistakenly think that a consequence will be more effective if it is more severe. This is simply not true. The impact of a consequence usually comes from the initial experience of the loss of privilege. After this, children often get used to having the privilege removed, and having an item gone for a long time, like a month, instead of a couple of days, likely won't motivate them to change their behavior any further. However, if the item is returned relatively quickly, within a few days, the possibility of losing it again may be something that would motivate children to modify their behavior in the future. So we recommend not removing privileges for more than 24 to 48 hours, depending on the age of the child and the privilege. In the heat of the moment, parents sometimes overreact and provide a severe consequence that they will not follow through on. For example, saying, I'm giving away your Xbox. In this case, parents can come back and change their minds, but this needs to be done on their own time and not in response to the child's behavior. So remember Dr. Ma's vending machine analogy. If the parent changes their mind in response to the extra button pushing that the child is doing, it will just reinforce the extra button pushing behavior, and they will likely end up doing more button pushing in the future. Finally, as we keep mentioning, consistency is really important between parents, across time, and across settings. So we hope that this presentation has given you some information that will help you to use Rolling with ADHD as a resource in your practice. If you start supporting a client in going through the Rolling with ADHD series and you get stuck and have some questions, you can always call the Compass team for guidance. We've also provided here a couple of books that would be helpful adjuncts for clinicians to read if they want to understand more about the strategies that are included with Rolling with ADHD. One of these is by Dr. Russell Barkley and the other by Dr. Alan Kasdan. We've also provided a few more additional resources for you to access. We have the Kelty Mental Health website and the ADHD webinar series that the Provincial ADHD program put together earlier this year. There are 5 talks in that series addressing different aspects of supporting children with ADHD. So we do highly recommend these both for clinicians and for parents to go through. We also have Rolling with ADHD for Teachers that is in development currently, so we're hoping that that will be available in the not too distant future to be offering for parents to pass along to schools for the teachers to access. We know we haven't addressed teens in this talk, and the Rolling with ADHD series is only for children generally around 6 to 12 years of age. However, it is important to note that generally the strategies that are discussed in the Rolling with ADHD program are still applicable for children, for teenagers. It's just that the way that they are implemented needs to be modified. So when we talk about providing fidgets for young kids, we might be talking about a fidget spinner, whereas for an older child, we might have something more age appropriate, like recommending that they have a water bottle with them. And when we talk about privileges and responsibilities that they have to show in order to earn certain privileges, those would look different as well. Potentially driving privileges, for example, would be the reward that they can work towards if they get their homework done, or something like that. There are a few resources specifically for teens that we do recommend. So there is, in particular for teens, it's helpful to target their executive functioning skills. And so in that case, there are a few programs that focus on kind of more organizational skills. So this one, homework, organization, and planning skills, the acronym HOP, is actually available online at the website listed, so anyone can access that. And then there's also Supporting Teens Autonomy Daily is a program created for teens with ADHD that incorporates some motivational interviewing, and that manual is there and available for purchase. In addition, we highly recommend Jessica McCabe's YouTube channel. So it's called How to ADHD. She also has a TED Talk about her experience having ADHD as an adult. And we find that a lot of her videos, which are quite short and to the point, and they'll address one specific topic per video within, 4 to 7 minutes. These have been found to be really useful by teens who can kind of resonate with some of the things that she talks about. Okay, so we now have time for some questions.
I'll also jump in to say that although the Rolling with ADHD program was targeting the age 6 to 12 years, then it really still applies very well to kids under the age of 6. And some of the specific examples that might be discussed, in doing homework, for instance, wouldn't apply to that age, but again, the strategies will still be very applicable. So for all the clinicians supporting the younger age group, please do consider using this as a resource as well, and then just adjusting the actual target behaviors and expectations accordingly. Oh, and then I will be doing a session for WCAIM, which is the Western Canadian Association for Infant Mental Health, in the fall. We're just finalizing the details of that schedule soon, so stay tuned for that, where I think it'll be more question and answers if people have specific questions in supporting kids with an ADHD-like profile under the age of 6.
Okay, thank you very, very much for the talk. That was super clear. We have lots of questions, but it looks like you were answering them as you went along. Definitely one of the most popular questions was around resources for parents of teens with ADHD, and you covered that towards the end. Just to add to that, somebody asked whether this is a program that's appropriate for a parent of a teen to work through with their teen, say like a 12 to 14, 15-year-old. What do you think about that?
It's a good question. I don't know how engaged the teen would be in watching the videos, but if they're willing to and interested in doing their own learning, I think it could be worth a try, keeping in mind that the strategies are geared towards parents and the language is talking to parents about different strategies. But I do in general think that the more kind of psychoeducation that teens can gather for themselves about ADHD, the better, so that they can learn about their own experiences and start to learn about what's going to be helpful for them. So I think of maybe more useful kind of strategy might be to go through some of those Jessica McCabe videos and have the teen actually watch some of those, and the parent can pick out ones that they think might be relevant. So yeah, I think that would be where I would start. And then if the parent, and I would also probably suggest maybe the parent go through the Rolling with ADHD program on their own first, and then decide maybe they can pick out little bits if there's anything that they want the teen they think would be relevant for them to watch, rather than maybe having them do the whole program, just because it isn't really geared towards a teen watching it themselves. Yeah. I don't know if you have anything to add, Janet.
No, I think that's exactly it. The Rolling with ADHD is parent coaching. So yes, a parent of a child 12 to 14, I think it'll still be applicable. Again, just understanding, adapting for age expectations. And then the YouTube, How to ADHD is Better for Teens.
Thank you. So one of the questions was actually addressing how physicians with less time in an appointment can support a family with this program. You know, because as we can see, this is a fairly time-consuming approach. What do you think about that? Any suggestions?
I honestly think sometimes it's even thinking about some of the very smallest steps that can be helping the parents. And so I even think if it's possible to get the parent in the moment to kind of sit with them while they sign up for the program. It seems very small, but sometimes just doing that step together can get them signed up, so then they're starting to get the notifications, as opposed to, you know, it can feel, especially we talk about the fact that most kids with ADHD have at least one parent with ADHD themselves. So if we're giving them a website to have to go home and look up on their own and then sign up, it's a lot to do, actually. And so even supporting with that could be helpful. And then just having those follow-up appointments to even create some accountability for the parent, so that the clinician is checking in, and the parent knows that the clinician is going to check in and say, oh, did you get through that? And especially for parents who are motivated to do some learning, then they might be more motivated to get through the module, so that because they know, well, now I'm going to have my appointment and I can ask some questions about what the content was, as opposed to not completing it. Of course, want to do all that compassionately and understand that oftentimes they won't be able to do it, even with that kind of accountability, and be understanding of that. But yeah, I don't know if you have more to add, Janet.
Yeah, I think that's a very good concrete suggestion, and I think similar to how we want to help parents understand, you know, how to fine-tune the tools, I think it's just so key for physicians and clinicians, anyone, to understand, kind of just assess that, oh yeah, they say they're using it, but you know, maybe there's just a little bit of fine-tuning you can suggest in a very short period of time. And then yeah, of course, that's also why we're working as a team. Sometimes, if you can, refer them to be seen with a clinician or a psychologist for more complex troubleshooting.
I think one helpful thing in particular, too, when you're kind of assessing whether they're implementing those strategies, is really to drive in and get some examples. Just ask them, okay, so what's an example of when you've praised your child for, and see what it's the flavor of it and what's actually happening. Because often parents will say, yeah, I'm doing this, I'm doing that. But then when they start to talk about it, then we can start to dig out some of those like fine-tuning and sharpening pieces that Dr. Ma just mentioned.
Thank you very much. I'm just wondering that we do get questions often about resources and where somebody might be able to find somebody who has specialism in ADHD or may be able to support them. Do you have any suggestions?
I think definitely you can do a search on the BC Psychological Association's website. They have psychologists that are listed there, and I do believe either there that you can kind of use the search term for ADHD. So that's a possibility if you're looking for a psychologist. I think Psychology Today and those kinds of search functions for looking for counselors and psychologists, I think they usually have a way to search for the term of what you're looking for, keeping in mind that most of the time that's kind of individual self-proclaimed area of expertise. So you might want to do a little extra research after finding a person's name and see if their physician or other professionals they're working with know of that individual. I think, and potentially, I think KDAC might have put out a list as well, and I think, I don't know how up to date that is, but so some of the websites and resources that are out there to support people with ADHD, I think might also put out some lists, but I'm not 100% sure. I haven't seen that recently.
Yeah, there's no perfect like go-to list, and I think the key is because we're getting the information out there for the clinicians and physicians as well as parents through Kelty about evidence-based interventions for ADHD, which includes the stimulant medications or behavioral approaches, less evidence for, let's say, like play therapy on its own, things like that, then it's just kind of helping families be aware of what to look for in terms of specialists and what they provide that is evidence-based.
Thank you, thank you. So there was one question around, it said how many people complete an intervention like Rolling with ADHD versus the number that enroll?
That is a great question. I don't have exact numbers, but we know that the graph looks something like this. So I have seen our numbers, and it's a quite significant drop-off after the first couple of modules, which is part of our motivation to get that information out there to clinicians so that they can help to bring that drop-off up a little bit so that more people are completing more and more of the modules. We have also recently switched the way that it is delivered. It is now, as you saw on the slides, in a learning management program so that parents can more easily navigate between modules and rewatch things if they want to, and they'll get badges and things like that as they complete the different modules. Previously, it was just sent out through email, so we're actually hoping that that will also have a bit of an impact on people being able to complete it, and they are getting some reminder emails now too. But any additional help from clinicians is definitely welcome.
Thank you very much. So I'm not seeing any more questions that we can respond to today. So I think that perhaps we can sort of end our talk. Do you have any final things to say before we finish?
I think it's just really great to get a lot of clinicians interested in this topic and particularly interested in supporting families with kids with ADHD from a non-pharmacological approach, that, yeah, like it really is not just meds, and that we know a lot of people might feel a little bit nervous not being experts in ADHD or in the behavioral management approach, but we hope that this program can be a really good guide in working with parents. And we didn't touch on everything. We just tried to help highlight some of the fine-tuning, but the program itself and the videos actually runs through a lot of the content itself. So the fact that you can support and walk alongside the family through these strategies that build on top of one another will be huge. So thank you.
Okay. Anything to add, Randall?
I think, yeah, Dr. Ma said that very beautifully, and I agree. I just think the more we can get this resource out there to families, the better. And I do think that a lot of families need a little bit of support in being able to do that. So we really appreciate everyone's interest today. Yeah, we hope that it was helpful.
Thank you very much. Thank you very much.